Hello, this is Dr. Tenkman. Today, we're going to talk about DMEK insertion, preparing the host, then loading and injecting the donor, partially and completely opening the donor, and then some challenge cases. First, special thanks to Garrett Mellis for inventing all forms of endothelial keratoplasty, and of course to Francis Price Jr., an amazing mentor and legendary surgeon who got me started in DMEK. There are many ways to do DMEK, and all of the techniques today are using the bubble beneath method. First, we have to store the donor while we work on the host. After tree fining and peeling the donor, I recommend setting the donor aside in storage solution safely covered. Drip storage solution drops adjacent to the donor to help move it to the center of the corneoscleral rim. Then, place 2 scleral fixation sutures and imprint the cornea epithelium with the same tree fine that cut the donor. A strip zone that is smaller than your donor could compromise attachment. Air affords better contrast and gives a better view while stripping. Stripping exactly at the trephination mark or peripheral to it minimizes the chance that there will be Decimase tags blocking the adherence of your donor. When air leaks out, you can have your non-dominant hand ready to refill. Even better, connect the air to an anterior chamber maintainer. During cases combined with cataract surgery, you're already going to have viscoelastic in the eye. Because of the lesser view, I recommend lifting the edge of Decimase 360 before attempting to peel it, as you would during DMEK prep. I think it's less likely to tear that way, but of course it still does sometimes. Frank Price taught me to check my work by lining up the Decimase on the surface of the eye and seeing if it's complete. Be sure to get all of that viscoelastic out. Dr. Price showed that can cause haze if you don't. He also taught me, and published, that trypan can help find tags of Decimase not initially seen. Loose tags stain dark blue. Bare stroma stains light blue. And unstripped Decimase doesn't stain or appears as negative staining against the lightly stained stroma. It also can block adherence. Leave no tags inside the trephination zone. Before I show you how I load the donor, let's talk about a few basic concepts. You have to stain the donor, but how much? Well, if you fail to get the stain inside the lumen of the donor where Decimase is, this may be your view, and you may have to restain the donor after it's inside the eye. Don't rinse out the donor with the stain. PBK, count fingers vision. Here you want a darker stain. I recommend 2 instead of just 1 minutes, but with good stain, the case will feel like a routine case. Almost. Get an older donor. They're less curly and easier to open. Remove the spring on this injector. Otherwise, it can aspirate the donor right back out the wound. Trust me on that. This is the 1.8 mm Viscojet injector by Bausch & Lomb. If you want to insert the injector into the wound and attain a watertight seal like we do with DMEK, it only requires a 2.4 mm wound. I recommend 2 Weck cells for the storage solution, then drip trypan into the lumen of the donor. You can even soak from the other side to help pull it into the lumen where Decimase membrane is. You don't want air in the cartridge, so you have to pour fluid through its lumen as you dunk it underwater. An air bubble could block its movement through the cartridge. Here's a separate example. Don't use 1 Weck cell from the side. The donor can move into it. These 2 Weck cells create equal and opposite flow, and the donor stays still. While fixating the cartridge with 0.5 forceps, drop the scroll into the fluid, gently guide it as gravity pulls it to the bottom. Gently advance it until it's safe under the closed lumen. Then close the cartridge until it clicks, Then load the cartridge, keeping it parallel to the ground, and advance the plunger until it creates a watertight seal right there. I'm going to rotate this double lumen scroll until it's right side up. I rotate it to the left until its connecting piece is on the bottom, then it's right side up. Before manipulating the donor, a suture makes extrusion less likely. I find the chamber less likely to shallow if I pass through sclera while lifting and then use counter pressure on the cornea. After opening the donor, if the anterior chamber stays deep, there's nothing to hold it open and it's going to scroll right back up. Use a cannula here because it lets you control chamber depth. You can kiss the donor between the iris and cornea and then do your A opening. Then it stays open so you can put your initial air bubble. Push out any air from your cannula prior to entering. You don't want stray air bubbles. Inject a slow, continuous trickle while you manipulate the donor. Otherwise, the chamber will shallow entirely and it will press the donor into your cannula. It takes the right touch. You don't want to deepen the chamber too much either, or else the donor will re-scroll, or worse, expulse. Push the inner lumen with the cannula or with fluid to make a capital letter A. Keep the chamber shallow so it stays open. Use a needle to place the initial air bubble. It keeps a closed system and nothing moves. After the initial air bubble is in place, you can deepen the chamber and the donor will stay open against the cornea. Let's talk more about injecting. What if, while advancing your plunger, the donor starts to approach the distal end of the injector and threatens to fall out before you've reached the watertight zone? Tap on the side to bring the donor back. You don't want it to reach the lumen before you've reached the watertight point. And to align a single lumen scroll right side up, put that letter V on the top. Hopefully it stays right side up after I inject it. Rotate and advance the injector until you clear the inner lip of the wound. Fill the chamber if it shallows. The pressure cannot cause donor override with this injector. The donor enters in a controlled small bolus. Now, before removing your injector, you want to make sure that the eye is soft and chamber shallow so that there is no exiting current that can take the donor out of the eye. Be especially careful in patients with blepharospasm. After releasing fluid from the side port as needed, remove the injector with the bevel down. It will dump less fluid that way. Just because this is a single lumen scroll doesn't mean it's going to be difficult. Carefully position the cannula into the lumen and burst fluid to help open the scroll. Then perform the A opening to the right and to the left, just as our other cases. Patiently persist. It can take time to find the lumen of the scroll. Now we'll talk more about partially opening and manipulating the donor once it has been injected into the eye. Art Giebel taught us that a circular current can rotate the donor. So can mechanical strokes on the epithelium. With either of these techniques, the goal is to rotate a misaligned donor until it is positioned with its lumen next to your wound. But so far, we've left out one important concept. Shouldn't we make sure it's right side up first? Fortunately, it always curls with endothelium out. So this would be wrong side up. As a cannula test shows, it cannot get into the lumen sliding to the right. The Eidolon slit beam is a bright and affordable slit beam that conveniently fits into a surgical glove so that it's sterile during surgery. You can aim it from any meridian to attain a perfect cross-sectional view of the donor scroll. Turn off the operating scope and the slit beam shows you that the edges of the donor curl away from the cornea. It's upside down. It's much easier to see in real life, but watch when I increase the contrast. Art Giebel teaches us to pull the edge of the donor under with a current to flip it. Not always that easily. You don't want to be out of control, but you need enough current to pull the donor's edge and to deepen the chamber some, so it has room to flip. So this would be right side up with the endothelium down. We know the donor is in the correct U-shaped configuration because the cannula can get into the lumen. Look at this picture. When the cannula slides to the right, its tip changes blue, suggesting it is under the curl correct orientation. Again, the A opening technique can push the donor open some. This other case had a really good view of a right side up donor on the slit beam. The connecting piece is away from the cornea, suggesting endothelium down, correct orientation. With the donor partially opened, right side up, and attached to the cornea, it's time to open the remaining folds. With the donor secured to the cornea partially open, it's safe to deepen the chamber and open the remaining folds. And this technique here is the bubble bump. The cannula is used to displace the bubble into the folds to knock them open. The bubble bump eventually worked here, but it doesn't work in all situations. In this case, the bubble bump was unable to open the remaining fold. Now there are other techniques that can open this fold. We'll talk about such a technique in just a moment, but remember the shape of this fold. On the left, it comes to a point in the middle. During my fellowship, I realized what's going on with these point-locked folds. Now this little point is a challenge, but I'll show you a solution. The right side of the DMEK will open easily by tapping the epithelium. The left side, when the bubble rose, it bent the middle of that fold. The crease, which ends as a visible point, locks the fold so it won't open. The secret is to press on this point and hold until the crease relaxes. Then it can open. Push and hold to unlock a fold. With the fold unlocked, the donor easily opens and centers with strokes on the epithelium. Go for a slightly elevated pressure. It helps the donor attach. Remember, push and hold to unlock a fold. We're going to push until the crease relaxes. Then release. It may take a few tries, especially on a sticky donor, but it usually works. It's important to keep the cornea moist during all these manipulations to prevent a defect. Once the donor is all the way open, as long as it's not a sticky donor, it centers easily with centering strokes on the cornea. We can center these donors exactly. Now what if your fluid opens the scroll, but it ends up being folded exactly in half? There's no left scroll to push on. And if you burst right, the donor will catch sail and crash into the angle. I found a solution borrowing from Dr. Giebel's flip current. Send the current underneath the donor, but don't flip it all the way, just stop pulling the lead edge once it's right side up again. Then finish as we discussed before. So we insert these single lumen scrolls right side up, but when we open them, they don't always stay facing right side up. This case has a strange semblance to a paper towel we just saw. It is folded exactly in half almost, with the crease on the right side. The flip current converts the donor from a 40-60 fold back into the Dead Sea Scrolls configuration. Then rotate and open the donor. Place the initial air bubble with a needle. It keeps a closed and controlled system. With no current going in or out of the eye, as would be the case when using a cannula, the donor stays still during bubble placement when using a needle. This donor is going to look like the mirror image of a paper towel we just saw. It opens into a 50-50 fold with the crease on the left. So therefore, a flip current should come from the left, directing the fluid underneath the donor. Patiently persist with small controlled bursts until the donor converts back to the Dead Sea Scrolls configuration. Then try the A opening. Some donors may take several tries and can be stubborn. This case reviews a few points. Here's a point locked fold. Now notice that while moving the donor towards me, it falls inferiorly. I get ready for a price pull, but tilting the eye up was actually all I had to do. With gravity on our side, the donor centers easily. Always use gravity to help you. When the donor is centered exactly on the tree find mark, fill to a slightly firm pressure. No pressure medications if they don't take them at home. And the rationale: we don't want an eye so soft that simply blinking could indent the cornea, as that could let fluid into the interface and compromise attachment. Sometimes after placing the initial air bubble, the donor is decentered, and it can't be opened because it's caught in the angle. A donor that's not opened all the way won't center well. A centering stroke will actually pull the curl and make it fold more. Start the stroke central to that curl, and as Frank Price showed me, this will center and open the donor in one maneuver. The price pull won't work until we first release any point-locked folds. Watch the vector. We start central to the curl, and it centers and opens in one maneuver. This would have been an ideal time for a price pull. The eccentric donor is just tapped instead, though, and the donor falls off the air bubble. Unfortunately, it had taken so long to get to that point in this status post vitrectomy case. Now for some challenge cases. Remember, after vitrectomy, the chamber doesn't shallow very well, which makes it difficult to keep the donor open. When the chamber won't shallow, nothing holds the donor still. You push side to side and the curl just moves instead of opening. And if you can burst it open with fluid, it's just going to curl right back up again. Here I actually aspirate fluid trying to shallow the chamber. While the sclera shrinks like a raisin, the iris stays deep. I tried to use an external cannula to push the roll open, but the chamber is just too deep. It seems that the only way I can open the scroll is with 2 intraocular cannulas. If only I had an assistant right now to inject the initial air bubble. Somehow I get it to open for just a second with 1 cannula. I verify it's right side up, but the needle won't penetrate. It's just too soft. I quickly sneak in a cannula and put in an air bubble, and then press the cornea to keep the air bubble under the donor. This sure would be a good time for a price pull, but it didn't work. So close counts as nothing. Getting desperate, I open it and hand the right cannula to my assistant, who does not have a microscope view. Stay still. I'll put in the air bubble. Wait, okay, stop. Oh, give me that. I'll take that. Thank you. I give, whoa. Okay, I don't know how it's staying open. Give me air on a cannula. Right there. Okay, keep that bubble under the donor. Push right there. Let's fill up the eye. Okay, mostly open but decentered. This is time for a price pull, and it better. Oh yes, it worked. What a relief. Believe it or not, her 6-month cell count was over 3,000. Watch this. This is the lucky trifold, or pilgrim's hat, that Jeff Ng talks about. It holds itself open, at least temporarily, in a deep chamber. Blood is not DMEK's friend. In my case from last year's film festival, I insert the donor and it's already right side up. I'm ready to finish the case. Because my donor is already right side up, and we're going to put it in unfold it, and...
Dr. Tenkman, we didn't make a PI.
Well, I can't use scissors. The donor could wash out with the irrigation. This needle will keep a closed system so that... Man, what are the odds? I can try to rinse some of it away, but not too vigorously. That donor's in the perfect position. Well, it's open just enough that I could go in with some air and just get it secured to the cornea. Quickly. Blood just filled the lumen of the DMEK. I have to rinse it out before it clots. This isn't working. Not at all. That bleeding is not stopping. Oh, Garrett Mellis. What should I do? Alright, this bleeding has to stop. I'm taking this pressure up until she can't see the light. And then we're going to wait. Francis Price, be with me.
They're starting to ask what's going on in here.
Oh, good. Thanks. Crap! We've got to move. Now let's rinse this blood out and take the pressure back down. This is what I was afraid of. There's clots stuck to the donor. That one is holding it to the iris. And here the entire lumen of the donor is filled with one massive clot. This donor is not going to open, not with that clot stuck inside of there. I can't seem to rinse the clot away. Whenever I try to aspirate it, the chamber wants to shallow. I certainly can't go in with a forceps. That's too high risk of damage. If the trypan keeps fading, this donor is going to turn invisible. Alright, here's an idea borrowing from phacoemulsification. This needle keeps a closed system. There's no current that could lead the donor out of the eye while I aspirate and occlude on this clot, and let's see if I can move it. Okay, it worked on that piece. Let's see if I... 20/20 within 2 weeks, and she had a great cell count. I now avoid all iris bleeding by doing all PIs with a laser before surgery. But the wound can also get you. Passing the needle through sclera sometimes causes bleeding. So we have to know how to deal with it. Sew that wound quickly. If you're fast, you can rinse out or sweep the blood before it clots in the lumen. And be careful with those surgical PIs. They can start bleeding again when the pressure falls later in the case. Last difficult case, the sticky donor. This guy doesn't want to move. I keep the cornea wet to prevent an abrasion, but this has been going on for a long time. I finally tilt the eye to put gravity on my side, and that's still not enough. After another minute, I go in and shrink the air bubble, and it still doesn't want to move. Art Giebel teaches us that small air bubbles create less upward force, less friction. This stickiness can make it difficult to center a donor and difficult to unlock a fold on a donor. I found that this stickiness can be due to the host. I've had patients who each eye the donor was particularly difficult to center, even when the donor's mate was easy to center in someone else's eye. I've also encountered donor pairs that were both difficult to center in separate hosts. Usually there's a pair that's sticky, both donors or both of the host's eyes. On this case, I finally give up and just fill with air off-center. Then the very next case, man, are these donors related? Why, yes, they are. Just like the previous case, this went on for a long time. So finally, I decided to carefully cheat with a forceps. Using a forceps is difficult if the chamber wants to shallow, such as eyes that have more posterior pressure. Fortunately, this chamber stayed deep.